morning to all of you. First of all, I thank the organizer for inviting me to talk before this August gatherings. So my topic is spectrum of 46 XY disorder of sex development, that is DSD. So I will cover, let me just a second. So can you see my slides? My slides are visible. Am I audible? So my slides are visible? Yes. Okay. So I will cover these subtopics under my topic. This is introduction, definition, etiology, scoring, investigation, hour-centered experience, and treatment or management. First, I will start with a case. This is a 1 year, 9-month-old child came to our OPD for evaluation of genital atypicality. Patient was born as second child of a consanguineous marriage, and he was passing urine through an opening below the shaft of the penis. There was no antenatal or perinatal complications, no history of any maternal virilization, and he was born by full-term normal vaginal delivery. There is no history of any hyperpigmentation or nausea, vomiting, loose stools, or any history suggestive of adrenal crisis. No inguinal hernias or surgeries, and there is also no family history of similar problem. So clinical photograph shows that there was micropenis, and there is hypospadias and incomplete scrotal fusion on the right side. Testis was palpable and of size of prepubertal, that is 1.5 mm bilateral. Investigations, hormonal as well as stimulation tests suggest that TDST, that is testosterone dihydrotestosterone ratio, was 12.75, that is more than 10, which is suggestive of 5-alpha reductase deficiency, and testosterone androgen ratio is not less than 0.8, that is more than 0.8. On imaging, prostate was hypoplastic and no Mullerian structures could be identified, and Wolfram ducts are normal. So this child is probably having 5-alpha reductase deficiency. So DSD, or disorder of sexual development, is basically a condition in which chromosomal, gonadal or phenotypical sex is atypical or discordant. The prevalence in the newborn is 1:4,500. DSD represents a broad range of conditions that can present at different stages of life. If we look into the development of male reproductive system, we can see that primitive gonads arises along with the adrenal gland from the medioventral region of the urogenital ridge at about 5 weeks of life, and primitive gonad separates after that and remains bipotential until 6th week of life, that is 42 days of gestation. Sertoli cells are the first cells to develop into the testes at 6th to 7th post-conception, and which secrete anti-Mullerian hormone from 7 to 8 weeks onwards. And then Leydig cells appear at around 8th week of life, which secrete testosterone. Secretion of testosterone causes stabilization of Wolfram duct, and AMH, which is secreted from the Sertoli cells, causes Mullerian replacement. Genital tubercle develops into the gland's penis. Urethral fold develops into the shaft of the penis and penile urethra. Urogenital swelling develops into the scrotum, and urogenital sinus develops into the prostate and prostatic urethra. And in male, usually the development of external genitalia, or that is sexual differentiation, is complete before 12 to 13 weeks of life. The numerous genes or transcription factors are involved in the development and determination of testis, and these are steroidogenic factor, tumor 1, GATA4, SRY, that is sex determining region Y, SOX9, MAP kinase 3K1, TSPI, PYL1, and MAMLD1, and several others. However, the most important genes which are important in determination of testis is SRY that is sex determining region Y, and SOX9. Now, there are hormones which directly influence the stabilization of Wolffian and Mullerian duct and the external genitalia. Usually, the testosterone is the main hormone which stabilizes Wolffian duct and develops vas deferens ejaculatory duct and epididymis. High concentration of androgen also has some paracrine effect, and AMH is the hormone which is responsible for regression of the Mullerian duct. DSD differentiates into prostate and external genitalia, as well as it helps in stabilization of the urogenital sinus. So these are the hormonal influences on male reproductive system. Now, testis initially is a intra-abdominal organ and which has to move to the scrotum during the fetal period as well as soon after birth. So there are two phases of testicular descent. One is called trans-abdominal phase, which occurs in between 8 to 10 weeks of life, which is dependent of INF-L3, that is insulin-like protein 3, along with the help of G protein coupled receptor, that is great. And this takes place by the contraction and thickening of the pubic ligament and also degeneration of the craniosuspensory ligament. In the later phases of life, that is 28 to 35 weeks, testicular descent takes place under the influence of testosterone and also with the help of probably androstenedione and genitofemoral nerve and its neurotransmitter CGRP, that is calcitonin gene-related peptide. Now, how to classify DSD? Broadly, it can be classified into sex chromosomal DSD, 46XY DSD, and 46XX DSD. Among sex chromosome DSD, there are Klinefelter, Turner, and ovotestis, as well as mixed gonadal dysgenesis. And in 46XX DSD, there is also developmental defect of the gonad, that is ovary, ovotesticular DSD, and also androgen excess, which can be in the form of congenital adrenal hyperplasia, that is CH of different etiologies, or aromatic deficiency, and also some androgenic drug when it gets exposed into the matter. Now, if we look into the causes of 46XY DSD, broadly it can be classified into gonadal dysgenesis group, that is development order disorder of gonads, and also disorder of androgen synthesis or action, and also disorder of AMH synthesis or action. So among this group, that is gonadal testis development, there is gonadal dysgenesis, ovotesticular DSD, testicular regression. In the androgen synthetic defect, there are several causes like LH receptor mutation, Smith-Lemli-Opitz syndrome, START protein deficiency, that is steroidogenic active regulatory protein, cholesterol side chain cleavage deficiency, 3-beta HSG2 deficiency, 17-alpha hydroxylase or 17-20 lyase deficiency, P450 oxidoreductase or POR deficiency, 17-beta HSG3 deficiency, and 5-alpha reductase 2 deficiency. Disorder of androgen action, it can be due to complete or partial androgen insensitivity syndrome, and also there is persistent Mullerian duct syndrome. Apart from these well-known causes, there can be of some anatomical defect like local anomalies, and also there are several other causes like congenital hypogonadotropic hypogonadism and endocrine disruptors. So these are the main causes of 46XY DSD. This is a huge list, and it is very difficult to diagnose that sometimes in 46XY DSD, what is the exact cause of this abnormality. If we look into the individual disease, briefly, this is gonadal dysgenesis can be complete or partial gonadal dysgenesis. Complete gonadal dysgenesis usually present as female phenotype, and they have obviously low testosterone level, AMH level, inhibin B level, and high gonadotropin levels. And gonads are usually dysgenetic completely. Then partial gonadal dysgenesis, phenotypical features can be ambiguous to hypoplastic male type. Mullerian duct can be present or absent. Gonads are usually dysgenetic. Again, hormonal profile, low testosterone, low AMH, low inhibin B, and high gonadotropin. So what are the genes involved in gonadal dysgenesis? There are several genes which are implicated in this disorder, that is gonadal dysgenesis. Number one, if we can think of WT1 gene mutation, that is Wings tumor 1 gene mutation. And this gene actually regulates function of several transcription factors like steroid factor 1, SOX9, SRY. And it helps in gonadal as well as the renal development. Therefore, a mutation of this gene leads to several syndromic disorder like WAGR syndrome, Wills tumor, aniridia, and genital phenotype mental retardation. Dennis-Drass syndrome, in which there can be early onset nephropathy. Frazier syndrome, there can be late onset nephropathy of FSGS. And Mitchum syndrome, or there can be cardiac defects or diaphragmatic hernia. Like these are the other single gene defect or transcription factor deficiency which can lead to development of gonadal dysgenesis. Some of them are like SF1, which is also associated with adrenal failure. GATA4 is associated with cardiac defect. SOX9 is associated with campobellic dysplasia and TSPYL, and DAX1 duplication and other transcription factors. So there are a host of transcription factors which can lead to gonadal dysgenesis. Next is LH receptor mutation. If there is mutation in the LH receptor, so Leydig cell will be unresponsive to the endogenous LH. As a result, there will be Leydig cell hypoplasia, which can lead to either female phenotype or ambiguity, sexual ambiguity, or hypoplastic male. Wolffian duct can be normal or hypoplastic. Mullerian duct are usually absent. Testes are present but small. So there will be testosterone and DST, which is low, and high LH level because of the LH resistance. Now, before we go into the different biosynthetic pathway which leads to XY DSD, we must just look into the figure of how steroid biosynthesis takes place in gonads and adrenals. So we can see that from cholesterol by help of star and P450 side chain cleavage, there is pregnenolone and then to progesterone. And another way is pregnenolone to 17-hydroxypregnenolone by 17-alpha hydroxylase. Then by 17-20 lyase, 17-hydroxypregnenolone or 17-hydroxyprogesterone can be converted into DHEA or androstenedione, and then with the help of 17-beta-HSD3, they can be converted further into androstenedione or testosterone. Testosterone can be converted by aromatase into estradiol. So this is the synthetic pathway of steroid. So any defect in this pathway can lead to DSD. So first in this group is Smith-Lemli-Opitz syndrome. It is due to the defect in the cholesterol synthesis, that is the deficiency of 7-dehydrocholesterol reductase. So as a result, because of the lack of the cholesterol, all the steroid hormones will not be synthesized, and there can be deficiency of all mineralocorticoid, glucocorticoid, and sex steroids. This is sometimes associated with different other anatomical features like microcephaly, syndactyly, mental retardation, ptosis, and other features. So hormonal profile will be low testosterone and other adrenal hormones, and high LH and ACTH hormone. And one of the interesting features is that patient will have low cholesterol level and high 7-dehydrocholesterol level. Next is deficiency of STAR, that is steroidogenic acute regulatory protein. Condition is also called lipoid hyperplasia. This is due to STAR is actually a protein which transports cholesterol from outer to inner mitochondrial membrane. So as a lack of STAR, there can be interrupted steroid biosynthesis. So STAR is not only the protein which transports cholesterol into the mitochondria, there are other pathways also. So in classical presentation, there can be severe phenotypes, and there can be deficiency of cortisol, mineralocorticoid, as well as sex steroid deficiency, and high LH and ACTH. So this is the histological picture of STAR deficiency. We can see this is normal, where this is mitochondria. So STAR helps in transporting cholesterol into the mitochondria, and here we can see because of STAR deficiency, there is less or no cholesterol transport into the mitochondria. As a result, there is accumulation of lipid droplet inside the cell, which leads to enlargement and engorgement of cells and destruction of other cell organelles and compromising the cellular function. And next in the line is P450 side chain cleavage deficiency. This is the enzyme which converts cholesterol to pregnenolone. So therefore, deficiency of these enzymes also interrupts the different steroid biosynthesis. So actually this enzyme controls 3 enzymes and 20 hydroxylase, 22 hydroxylase and side chain cleavage enzymes. So phenotype can be severe or partial, and so phenotype can be female type phenotype, or it can be hypoplastic male. Next is 3-beta HSD2 deficiency. It can have classic form of severe adrenal insufficiency or non-classic or mild form of hypoplastic male. This enzyme converts actually delta 5 to delta 4 steroid, that is pregnenolone to progesterone, or pregnenolone or 17-hydroxypregnenolone to 17-hydroxyprogesterone, also androgen biosynthesis. So in this disorder, particular in this disorder, there can be high 17-hydroxypregnenolone after ACT stimulation, and also called ACTs can be high. Next is 17-alpha hydroxylase or 1720 lyase deficiency. 17-alpha hydroxylase converts 17-hydroxylation from pregnenolone or 17-hydrox or progesterone to 17-hydroxypregnenolone or 17-hydroxyprogesterone. So presentation can be female or ambiguity or hypospadias with micropenis, that is hypoplastic male. So hormonal profile, it will be low testosterone and cortisol and increased LH, FSH and increased deoxycorticosterone and also corticosterone, progesterone. And an unusual and important feature of this condition is hypertension and tall stature and delayed bone age. Next is P450 oxidoreductase deficiency. POR is important for 3 crucial enzymes. It acts as a basically cofactor for all these enzymes, and these are 21-alpha hydroxylase, 17-alpha hydroxylase, and 1720 lyase. So if there is POR deficiency, there will be combined deficiency of CYP21 and CYP17 deficiency. This condition is associated with an important syndrome, which is called Ackley-Bixler syndrome, and which is manifested by craniosynostosis, proptosis, midfacial hypophagia, and also humoral bowing. Next is 17-beta HSD3 deficiency, which converts aldosterone to testosterone. So there will be reduced testosterone in this condition. Phenotype can be variable from female phenotype to ambiguity to hypoplastic male. And 2 important features of this condition is peripubertal or pubertal gynecomastia, and also there can be virilization during the puberty because of the other presence of other isoenzyme of this enzyme. And from diagnostic point of view, if we do the post-HCT stimulated testosterone and androstenedione, then the ratio will be less than 0.8. 5-alpha reductase deficiency. 5-alpha reductase, which converts testosterone to dihydrotestosterone, which is more potent androgen than testosterone, and which is responsible for virilization of external or male genitalia from prostate and onwards, results in sexual ambiguity. So there can be severe hypospadias with micropenis along with blind vagina and pouch, and sometimes the phenotype can be just like female phenotype with pubertal virilization. So pubertal virilization due to backdoor pathway or alternative pathway which occurs during the puberty is another important feature, and this condition is another important condition which can cause gender change at the time of puberty. Next, androgen insensitivity can be a complete or partial androgen insensitivity syndrome. Complete androgen insensitivity syndrome actually can present with female phenotype with lack of hair, that is, it is called, or sometimes it is called hairless woman. And obviously, the patient is having high testosterone level because of the presence of testes. So this is one important condition which can present with female, but in the pubertal period, they can present with just primary amenorrhea. And during the course of investigation, we can see that actually the karyotype is 46XY. Partial androgen insensitivity, actually it is a common cause of 46XY DSD. It presents with ambiguity or hypoplastic male, that is hypospadias, micropenis, and all sometimes undescended testes. So hormonal profile, there can be increased testosterone and LH and FSH level, but it is difficult to understand in the prepubertal age sometimes. And also they can present with gynecomastia at puberty. Persistent Mullerian duct syndrome, this is another condition due to defect of AMH synthesis or AMH function. So there can be persistence of Mullerian structure inside the body. So Mullerian ducts can be present. Testes are usually gonads are usually testes, and usually they are descended. But sometimes because of the Mullerian structure, there can be torsion or testicular cancer or infertility. And they can also present with inguinal hernia with Mullerian structure as well as the gonads. Ovotesticular DSD, this is another form of XY DSD, or it can be also sex chromosomal DSD. So most common karyotype is 46XX 70%, and 46XX and XY is 20%, and XY is 10%. So it can be of lateral, unilateral, or bilateral. Unilateral ovotestis is the most common. That suggests that there is ovotestis in one side and testis or ovary on the other side. So actually this patient have both testicular and ovarian tissue in their body, and they can have important features like cyclic hematuria or also asymmetrical genitalia and inguinal hernia. Mixed gonadal dysgenesis, this is another condition in which karyotype is usually 45X and 46XY, and they can present with ambiguity, sexual ambiguity, or they can present with also female phenotype. Their gonads can be dysgenetic ovary, normal or dysgenetic testis, or straight gonads, or ovotestis rarely. And hormonal profile can depend on the presence of gonadal dysgenesis and the function of the remaining gonad. So they can also present with asymmetrical genitalia. Important feature is that they can also present like Turner-like syndrome or short stature. Now coming to approach to a case with XY DSD, how to approach such a case. So the basic principle is bonding, adrenal insufficiency, sex designation, imaging, and cytogenetics. When to suspect disorder of sex development or DSD, if there is clear-cut ambiguous genitalia, or if there is apparently female genitalia with bilateral inguinal mass hernia or clitoromegaly or posterior fusion, apparent male genitalia with severe penoscrotal hypospadias, bilateral non-palpable gonad, and severe hypospadias with micropenis and undescended testes. And when there is genotypic phenotypic discordance, and also there is family history of similar disorder. So history is very important in evaluation of DSD. There can be consanguinity. Consanguinity can lead to several autosomal recessive disorder like enzyme single single enzyme defect like 5-alpha reductase deficiency or partial androgen insensitivity or other congenital adrenal hyperplasia. Maternal virilization during pregnancy that clues to placental aromatase deficiency. Salt losing crisis can suggest adrenal insufficiency or CAH. Similarly, gynecomastia can be feature of 17-beta HSD3 deficiency, partial androgen deficiency, or ovotesticular DSD or mixed gonadal dysgenesis. When we examine a case of DSD, we have to, particularly in 46, we suspect 46XY DSD. So this score can help whether patient is really has problem or not. There are 4 points like scrotal fusion, micropenis, urethral meatus, and presence of gonads. So accordingly, it is scored, EMS score, that is external masculinization score is calculated. Total score is 12, and if the score is less than 11, that suggests the patient should be investigated for DSD. Now, if gonads are palpable and karyotype is 46, then there is high probability of 46XY. However, gonads may not be palpable always. There can be undescended testis or fetal criticism in 46XY DSD also. So AMH can help, because AMH, if it is low or undetectable AMH, that can suggest dysgenetic gonads, that is dysgenetic, DSD or gonadal dysgenesis. However, if it is normal, it is not much helpful. And then there are other tests which can identify different block or biosynthetic defect. Coming to the genetics, it plays important role in the diagnosis of DSD, karyotyping, FISH, quantitative fluorescence, PCR, array analysis, single gene analysis, target panel sequencing or whole genome sequencing. All these are tests which are now available, though not available clearly in all of our institution, and we cannot do much of this genetic test many a times. However, these are available and they are immensely helpful in to reach a specific diagnosis of cause of DSD. Endocrine evaluation, apart from routine biochemistry investigations, other important investigations which help in the diagnosis: 17-hydroxyprogesterone in CAH, 11-deoxycortisol, 17-hydroxypregnenolone, and of course testosterone, androstenedione, dihydrotestosterone, both basal as well as stimulated, ACV stimulated values. Gonadotropins can also help, particularly in case of androgen resistance. AMH inhibit B, which can be useful markers of integrity of the testis and function of the testis. Urinary steroids by GC or mass spectrometry, they can also help in particular defect in the biosynthetic pathway of gonadal steroid synthesis. So imaging are also helpful. USG and MRI are helpful to detect the intra abdominal structure, particularly internal structure, internal genital structures, and also sinogram, cystoscopy are the other investigations which are necessary in some of the cases. And laparoscopy is another method which can detect internal structures by direct visualization, like gonad and Mullerian duct diabetes can be seen directly and help in the diagnosis. And also it can help to take biopsy to identify dysgenetic gonad or overdestis. Now this is diagnostic algorithm in the newborn. You can see after karyotyping, the old approach was hormonal evaluation, then imaging, then the molecular diagnosis. Now currently they are suggesting after karyotyping, you divide it into 46 XY or XX or 6 chromosomal DSD, then go for urgent metabolic tests like electrolytes, glucose, and 17-hydroxyprogesterone, and then go for next genetic testing, that is a molecular diagnosis by whole genome or targeted panel sequencing, and then targeted endocrine and anatomic evaluation. If we look at the different studies in Indian scenario, one study by Walia et al. From Chandigarh, we can see that there was total 102 XY DSD, and among the most common XY DSD was androgen insensitivity syndrome. Another study from G&K by Dar et al. Among 10 cases, the most common case was XY DSD. This is another study from AIIMS New Delhi by Hallar et al., where total cases of 63 cases, 40 cases had XY DSD, and most common was partial androgen insensitivity syndrome. This is another case from Brazil, 93 cases, 46 XY DSD, 50%, no cause could be found, 20% cases androgen insensitivity syndrome, and 17.2% cases 5-alpha reductase deficiency. So we had a small study in our institution, cross-section survey of 46 XY DSD. We found that 11 patients had, that is 55% patient had 5-alpha reductase 2 deficiency, and 6 patients, that is 30% patients, had partial androgen insensitivity, and 3 patients had 17-beta HSD3 deficiency. And the most common presentation was hypospadias, particularly penoscrotal hypospadias, and microsphenis were the next common presentation. Cody was presenting 8 patients. Now, if we look at the different presentation of 5-alpha reductase deficiency, partial androgen insensitivity, or 17-beta HSD3, we can see that micropenis and hypospadias more common. Particularly micropenis is more common in 5-alpha reductase deficiency and also hypospadias. And EMS score, mean score in the 5-alpha reductase 6.18, in the androgen insensitivity syndrome 8, partial androgen insensitivity 8.17, and in 17-beta it is 4. Stretch penile length in 5-alpha reductase 2.96, in androgen insensitivity syndrome 4.58, and 17-beta 4. So we did testosterone and other ACG stimulation tests, and we can see that we diagnose 5-alpha reductase on the basis of elevated T-DSD ratio and 17-beta by reduced TA ratio that is less than 0.8. We could not do molecular diagnostic tests because of the lack of resources. We have a plan to do this in the future. Now, if we go into the just briefly management of DSD, so it is a management is completely a team approach. It's not one man's job. So we need endocrinologist, urologist, psychologist, and then pediatrician, of course, pediatric surgeons, biochemist, and cytogenetics or geneticist for diagnosis, and then histopathologist and radiologist, and also social worker, community leaders, ethicists, nurse specialist, gynecologist. So it's a large team, and all of them help to diagnose and properly manage the DSD cases. So management of 46 XY DSD, if male sex is designated or assigned, then correction of body present, and then urethroplasty if there is hypospadias, or phalloplasty if there is micropenis. Orchidopexy can be done at the proper time, or gonadectomy if there is high risk of gonadal germ cell tumor. Testosterone supplement to be given if there is hypogonadism. After puberty, fertility assessment to be done, and if possible and plausible, then ERT can be considered. Cosmetic surgery, mammoplasty can be undertaken if there is gynecomastia, particularly in some of the cases like partial androgen sensitivity syndrome or 17-beta HSD3 syndrome. If female sex is designated, then vaginal dilatation if required, then or laparoscopic vaginoplasty or pelvic floor repair. Clitoroplasty or gland sparing or nerve sparing clitoroplasty is preferred. Gonadectomy if there is high risk of GCT, and or hernia repair if present. Estrogen supplement to be given if required, or combined estrogen progesterone supplement if uterus is present. So therefore, to conclude and summarize, 46 XY DSD and also DSD is a complex endocrine problem, and it's an emergency problem in some cases, and which has phenotypic diversity starting from mild to severe cases. Early diagnosis is helpful and essential in some of the cases in deciding gender designation and sex bearing. Hormonal evaluation is also essential to tackle different life-threatening conditions like adrenal insufficiency, and also help in the diagnosis. Genetic analysis play a very crucial role in to make or reach a specific diagnosis of DSD if resource permits. And also we have to address the psychological and social issues of the parents and also the patient. And also we have to focus on the improving the quality of life, and also management complication like germ cell tumor. And also we have to counsel regarding the fertility aspect. And multidisciplinary team approach is the key to manage this condition. Thank you for patient hearing. I must end here. If you have any questions, I can.